we all want to learn how to perform bifurcation stenting successfully. And please tell us your strategy for bifurcation stenting.
Okay, thank you first of all for having me with you, and it's always a pleasure to be at Asia Pacific TCT. The first question to be addressed in bifurcation stenting is to evaluate the size and the distribution of the side branch. How important is the side branch, and how important is to achieve a good result on the side branch. If the side branch has a large territory, it means that you do not only need to keep the branch open, but you need to have a good final result on this artery. So this is the first question. The second question is, do we have disease as a side branch, ostium? Yes, no. Does the disease as a side branch ostium extend further down from the side branch ostium? So if the side branch is large, has a large territory of distribution, has disease as the ostium, and the disease as the ostium extends a little bit further down from the ostium, 5-6 millimeter, I believe you have to think about the possibility to use two stents. If the side branch has none of these features, or only one of these features, like if it's small or has no disease extending from the ostium, you will start with one stent, keep a wire in the side branch, and then make your evaluation and decide. The smaller the side branch is, the smaller the territory of distribution, the less likely will be that you have to implant a second stent. The most important is not to close the side branch. We like to keep a bifurcation. We don't like to simplify and make a bifurcation a straight artery.
Do you think IVUS examination is essential in bifurcation coronary stenting?
I do not think it is essential. I believe it is essential in situations where you are uncertain. You do not know if the side branch has disease. You do not know about the correct size of the vessel. I would say it is essential every time you think about implanting two stents, and is also essential every time you have implanted two stents. If you have implanted two stents, you must be absolutely sure that you have obtained a good result. And in order to do that, you have to check with IVUS. And what do I mean for good result? Good result, I mean to achieve a good stent lumen, which means if you are using a 3 millimeter stent, you must reach at least a cross-sectional area of 5 or 6 square millimeter. If you are using a 2.5 stent, you should get a 4 millimeter square cross-sectional area. If you achieve these sizes, I believe that you will have a good long-term result, even if you use two stents.
And what type of technique do you prefer for using two stents in bifurcation lesion?
For two stents in bifurcation lesion, I use mainly mini crush or TAP, T and protrusion. Mini crush has intention to treat when I need two stents, TAP, T and protrusion when I cross over from provisional to two stents. Sometimes I would say I also use culotte So I would say the three techniques are culotte, mini crush, and TN protrusion. Always I do kissing balloon inflation, but more important is to do high pressure inflation separately first. First on the side branch, second on the main branch, and then together.
So you first do the sequential ballooning and then the final kissing.
Always important to do sequential first.
What should we do to reduce the rate of stent thrombosis for bifurcation stenting?
I think the most important is do exactly what we discussed. Make sure that you have implanted a stent in a vessel which is not too small, which does not have a good distribution. If the flow is very limited, you should not implant a stent. And every time you implant one or two stents, even more, you must check that the result is optimal. And as I said, every time you use two stents, you should do IVUS on the main branch and on the side branch. Every time you use two stents, you should do sequential kissing with high pressure balloon in each branch and then medium pressure together. Kissing is not essential when you use one stent. I would say that is preferable. I tend to use kissing, especially if the side branch has been pinched after implanting the main branch stent, but I don't do kissing when I implant one stent always. I would say maybe 80%. When I implant two stents, I do it 100%.
Thank you for your talk and thank you.